Hello, everyone. This is Adnan Sadie from Virginia Mason. So I have the privilege of moderating. Dr. Jackson from Dallas has made a really nice presentation. As Rohan said earlier on, our plan is to make this very interactive. There are a very short presentation in the beginning, then 3 cases. We may not get to 3 cases. The key here is to kind of discuss things that are more of a fellow level. So we'll ask some questions as we go along, and if you have a question that you want to type as Dr. Jackson is presenting, you can do that by using the chat format, and we'll get started. So Dr. Jackson, please proceed.
Good afternoon. Good afternoon, everyone. Great welcome to our eminent guests, respected teachers, and to all of my beloved friends and colleagues. Thank you for allowing me to present today. I would like to talk about an HPB surgeon's perspective on bile duct injuries. We'll talk about the clinical impact of bile duct injuries on our patients. We'll discuss the various patterns of presentation and that are pertinent to the care of these patients. We'll go over a few case presentations, discuss some specific nuances, early versus delayed repair, whether or not to use a PTBD, revisional surgery versus liver resections versus liver transplants. We won't have time to go into prevention of bile duct injuries, but there's a great resource. Please take a look at this website when you get a chance. It's a consensus forum that's been created by multiple surgical societies. PreventBDI.org, great resource, lots of literature that you can get from. I would encourage everyone to take a read. Starting with the incidence of cholecystectomies, traditionally open cholecystectomies have had a slightly lower incidence of bile duct injuries, compared to laparoscopic procedures. And laparoscopic procedures have had an incidence of about 0.2 to 0.5%. This incidence was slightly higher in the 1990s and believed to be secondary to a learning curve of the laparoscopic procedure. It is overall plateaued at this range. In terms of the clinical impact, this is from an older paper, a public database, which showed a fairly high mortality within the first year from bile duct injuries, up to 26.7%, and at a period of about 9 to 10 years from the injury, only 19.5% of these these patients were alive. The real numbers may not be this high, but it truly goes to show how bad this disease can be. Bile duct injuries has a long-term impact on all of these patients. It has a 62% chance of mortality from cholangitis, 4% chance of mortality from any liver disease, 2 to 3% mortality, 2 to 3 times the mortality from cirrhosis, and 5 times overall mortality when compared to an uninjured patient undergoing laparoscopic cholecystectomy. Now, and the impact is not just clinical. When we look at the functional status of the patient in terms of their social function, physical function, their emotional status, immediately after the injury, you can see the blue line right in the center. Most of these patients go back down to 10% or 20% of their baseline function. After repair, even 10 years after the repair, they do not recover to 100%. So it's a lifelong impact. Now, what else matters from an HPB surgeon's perspective? How they present. There are many facets of their presentation. First of all, the clinical presentation. They present to us acutely. They will present either with jaundice or with ongoing with bilious peritonitis or with cholangitis. Sometimes they present to us in a delayed fashion, which would present most commonly as a benign biliary resection. And if it's even more delayed, liver failure, atrophy, cirrhosis. And in situations where there's a concomitant vascular injury as well, they would suffer from hepatic abscesses also. Now, from an HPB surgeon's perspective, it is not just the clinical presentation that matters. Most of these patients are not referred to us immediately. Only about 19% of these patients are referred immediately. 58% of them are referred within a month. 40 to 45% of these patients undergo 1 to 3 procedures prior to referral. These procedures range from bilioenteric anastomosis, an end-to-end anastomosis, or an exploration and an attempted repair. The mean time of referral is 29 days. And this is a place where we can make drastic improvements. And it's not just in terms of educating the index operator, the index surgeon. It's also in terms of being more available from our standpoint for all the surgeons, not just being a name or on a name card, being a face, a cell phone number, being easy to contact to, or doing more outreach. So this is a place where all the surgeons, including us, can make tremendous improvement. Another facet presentation includes the type of injury that they incur. Most patients that are referred to HPB surgery suffering from a major injury. Minor leaks and minor injuries are many times not referred to HPB surgeons at all. And the classic injury that's described is an excisional type of a bile duct injury, where the distal bile duct is misidentified as the cystic duct, clipped and cut, and then dissected further towards the liver hilum, where it's identified as an accessory duct and clipped and cut again. And this is a picture showing a classic type of CBD injury. Before we proceed, I was going to show the Asperg modification of the Bismuth classification for bile duct injuries. One of the most commonly used classifications. It gives us all a common language and describe these injuries, and helps us plan for operative methods. And in some ways, also it gives us an idea about the prognosis. We'll move on to our cases. Any questions at this time? The first case we're going to talk about is a 39-year-old female who presented to us 4 days after a laparoscopic cholecystectomy, which was done for cholecystitis. When she presented to us, she was in more pain than was anticipated. She was jaundiced. Her bilirubin was 5.2. She had an elevated alkaline phosphatase and her white blood cell count. She was leukocytotic. When we evaluated her with an RCP, this is what we found. You can see a clear discontinuity in the bile duct going straight up towards nearing the confluence of the hepatic ducts. This was anticipated to be a classical type of bile duct injury. We performed a contrast analysis to make sure there was no concomitant vascular at the same time, and offered her an immediate repair. We performed this in an open fashion. When we performed the laparotomy, there was some bilious fluid in the abdomen. The injury was found to be within a centimeter of the circumference of the head. We performed a cholangiogram to make sure that the opening that we were seeing encompassed both sides of the biliary tree. We performed a Roux-en-Y hepatectomy and placed an intraperitoneal drain. Patient's postoperative recovery was fairly uneventful. Now, I would like to come to certain nuances in the care of this patient in terms of timing of repair. We have delayed this. And secondly, for this E-type injury, what type of repair techniques were we used?
So Dr. Jackson, let's stop there for a second. That's okay. And so I just remind everyone that if you're not talking, please mute your microphone. So we'll start with Dr. Sandoval from Oregon Health Sciences. So Dr. Jackson presented a case there. There's a lot of things to ask, but I would love to kind of get your input on how you preoperatively, so you just had a post-op day for bile duct injury transferred to you. What would you do preoperatively to actually map this patient, and how would you decide to proceed to the OR or not? Compare that to what Dr. Jackson there presented.
Hi, thank you. I think the most important things to find out first are level of injury and if there's a concomitant vascular injury, and then put that in line with timing of the injury. I think are the most important things to identify right off the bat.
So what imaging modalities do you guys use?
I think probably starting with a CT scan is reasonable, and then probably either an MRCP or ERCP, depending on where you think the injury is.
Okay. So in this case, they used a CT. There was no vascular injury. The patient seemed to be stable. They did an MRCP, which shows an E-type injury. Sometimes MRCPs kind of over-exaggerate the injury. Sometimes they don't, depending on whether it's a clip duct, a dilated duct, or a free-flowing duct. But how do you decide whether to go to the operating room or to do a delayed repair? And maybe we can ask your colleague, Dr. Wanakta.
Yeah, I think as Vic had noted, I think there's other facts of understanding if there's a vascular injury as well. But I think part of it is also looking at your patient in the sense of if they're septic and whatnot, making sure you're treating those factors. But I think in an otherwise healthy patient, less than a week, I think after a week you're starting to push it. But I think it was in that time frame, that's a reasonable time to go versus, if you're starting to get to closer to 2 weeks or a very late injury or a late presentation of it, that would be someone I would wait at least 6 weeks. And if you need to decompress them with, say, like a PTC or something along those lines before actually taking them to the operating room.
Thanks. Thank you for saying that. Any comments or questions about that topic? I mean, that comes up a lot, early versus late. I think most of us would feel that if patient, as you said, is stable, not septic, and no vascular injury, then early is better probably. But the issue of what do you do when you have somebody with tiny ducts, and that's probably where the controversy is. And maybe somebody wants to comment on that. If a patient is stable, no vascular injury, but you map them, or you're basically an obese patient, tiny ducts, does anybody delay simply to dilate the ducts? Delay repair for that purpose only?
Emilio from Providence. Yeah, you would delay. You wait. You allow that area to. You remember, we're doing this for benign process. This is going to be a repair that is going to last the patient for life. So minimizing the risk of a stricture in that anastomosis and that bilioenteric anastomosis is the most optimal thing. So you provide the patient with the most optimal situation to allow that to heal with the lowest risk of stricture later on.
Yeah, can you, I'm sorry, it comes up as caller number 2. Can you introduce yourself?
Emilio Alonso from the second year fellow here at Providence, Portland.
Awesome. Thank you, Emilio. Any other comments on the timing of repair?
So, Adnan, I wanted to ask 2 questions. Do you think that the presence of does anyone think that the presence or absence of a biloma makes a difference? And second of all, is there a role for ERCP in these patients at all?
Good questions. How about we ask Dr. Salibi from Carolinas to answer those questions?
Hey all. Yeah, interestingly, we were just having a private conversation on this side, specifically referring to this exact scenario. And so, yeah, we've had a couple cases actually here recently where we've had significant bilomas or bioperitonitis. And even in those situations, when they've been early presentations, we tend to err on the side of controlling the contamination source, so washing them out, placing drains, and then bringing them back in a delayed fashion for definitive repair. And that tends to be our preference. The patients tend to do better. Yeah, and we are open to doing that laparoscopically in a minimally invasive fashion, washing them out if needed. One of the more recent ones we've had, we ended up doing open just due to the degree of contamination or to adequately control his sepsis.
So it seems like it's a judgment call. You go in there and small biloma, patient stable, no vascular injury, then maybe watch out and actually do a repair. But if bile peritonitis or certainly a patient has septic phenomena, then you delay. Is that correct, or am I paraphrasing correctly?
Correct. Yeah, we tend to err on delay in the presence of bile, but correct.
I think, Dr. Niraraja, with respect to your second question, I think all of us would feel that ERCP is probably not the first place to start unless you really think it's a type D injury. But if you have a a picture like you had with an MRCP with a type E injury, I'm not sure anybody would do an ERCP, unless somebody wants to disagree with that. Dr. Tomei,
this is Mike Jacobs here. We would generally not favor doing an ERCP there, but just to speak to the comment about the biloma, I think you have to differentiate between diffuse peritonitis from bile, which would be done through a washout, either laparoscopic or open, leave wide drains. If they just have a simple contained biloma, by all means, we would drain it percutaneously and let things cool down for a while.
Well said, I agree. And I'm sorry, did you say you would or would not CP?
If this was directed to Mike Jacobs, I said no ERCP.
Yeah, I agree. So let's move on to the second question, if we could. Dr. Tomei from Pittsburgh. The second question that Dr. Jackson has on there, which with respect to what enteric, what valve, if you will, we use to repair. Obviously, we're not talking about a situation, we're talking about an injury, and we're not talking about a situation where the duodenum is problematic or looks ratty or anything like that. In essence, in a situation where you have a healthy duodenum, would you use the duodenum, or would you do a Roux-en-Y hepatocoaguloplasty like you saw?
So we commonly use here Roux-en-Y hepatocoaguloplasty as our standard for a clean duct.
And any reason besides common practice?
One, common practice. Two, I think most of them when they're a bit on the high, like especially when there's a biloma or anything, usually the area where the duodenum is a bit hard to dissect to bring up. And then that J works nicely. I'm not sure about, like, there's some literature that says a common bioduct duodenum where you may run into the SUM syndrome, but we have done it for a couple of patients before the residency when there was problems with stone. We have done choledochal to duodenum, but we have not run into that complications after.
So this is kind of an area that's really more a little bit in flux. You said something about SUM syndrome. Like, is a SUM syndrome a problem, or theoretically a problem, in patients who are basically going to have a repair with a discontinued bile duct, right? So a SUM syndrome, you really are talking about it when you're doing like a choledochal duodenal side to side. But in this case, you're basically taking the duodenum directly to the liver. So really, most people are concerned mostly with more frequent cholangitis than using a diverted route as well. So anybody comment about that? Whether they prefer? Anybody with experiences with a lot of using the duodenum? Anyone against duodenum sharply or strong feelings? I think Dr. Strasberg may be on as well. Would love his comments on this topic.
This is John, Carolinas. We were just having another private conversation about this topic. I would strongly encourage fellows not to try to use the duodenum as a primary repair for a bile duct injury. Probably would not be received well on their oral boards. And there's a couple of reasons for that. One is it's not a vascularized limb it doesn't have its own blood supply like the roux limb of jejunum. And secondly, if you have a leak from that, you now have two leaks. You have a bile leak and a duodenal leak. Whereas if you have a roux limb, it's really just a blind limb. And no leak, generally speaking, a leak from that is going to close on its own. Whereas a leak from a choledochal duodenoscopy or something is a different story. So I strongly feel that's probably not the right conduit to use for bile duct repair. All things related.
I have to say that the only time I've ever used the duodenum is in settings where the infracolic bowel is hostile, if you will, like in patients with a lot of surgery in the past, or if they've had a Roux-en-Y gastric resection, something like that. But I see your points. Any other comments on this topic?
Yes, it's Brendan here at Stanford. So I sometimes use the duodenum for older patients with stone disease, and then I think an end-to-side coloduodenoscopy is a nice, easy operation in somebody who's a big dilated duct from chronic stone disease. I think it does have the potential for reflux cholangitis, so that is something that is clearly overstated and over-worried about, as is the double leak phenomenon over-worried about. The pediatric surgeons are using the duodenum all the time now, much more so than in the past. I helped them with a subset of their complex coloductal cysts, for example, because in pediatric cases, roux limbs have a separate, unique set of complications that we don't see in adults, which is mostly torsion. And yet in kids, they can have a hepaticoduodenostomy, and the vast majority do well, though I have now seen a couple of their 19-year-olds who have started to develop symptoms from reflux into their biliary tree. So I think the default still remains a roux. There are some indications for coloduodenoscopy, and so and obviously there are some surgeons, even probably on this call, including your partner there at Virginia Mason, who have experience and good luck using it. So I don't think one can dismiss it entirely. There's probably the right case for it now and again.
That's a nice summary.
Yeah, this is Mike Jacobs here. I think whether you do choledochal or hepaticoduodenostomy depends on the condition of the tissue and the ability to free it. And we've had scenarios where patients have had bariatric procedures and bile duct injuries after a Roux-en-Y, not from the bariatric surgery, but from the cholecystectomy. And if the conditions of the tissue are healthy enough and permit mobilization, they're generally not very technically difficult. I prefer a direct end-to-side and tie off the distal bile duct after I've done a choledocoscopy or a cholangiogram just to exclude distal stone disease. So it just depends on the woodiness of the tissue, though, and the ability for mobilization, presence of any pancreatitis that may limit your ability to mobilize the tissue.
So thank you, Mike. And so we'll proceed. Those are nice summaries. Thanks everyone, and thanks Brendan. We'll proceed with Dr. Jackson to kind of summarize. I think we all seem to be on the same page. There's really no major literature that's going to push one way or another with respect on the bowel. I do think that in terms of repair, we do want a wide repair, and so we tend to, I think the classic would be a Hep Quinault, which Dr. Jackson will go over. The other thing to keep in mind, which comes up a lot, is this whole idea of obviously a sump syndrome, which is an issue really, as we said, for side to side to common bile ducts, but not really for this type of repair per se. So, Dr. Jackson, please proceed.
Thank you everyone for your comments. These were just two great quotes that I found in some of the articles that I read. It's always better to operate on a patient when we have accurate anatomic diagnosis and the patient's prepared before before inflammation sets in. And the other one is a quote from Dr. Lilimo talking about placing PTBDs in settings of biliary peritonitis to buy time, allow the inflammation to settle down. Now, why would I be presenting quotes rather than data? Because when we look at data, it is so heterogeneous. And I want to give a shout out to Mohammed El Tamimi at Indiana University, a good friend, my colleague. He and I worked on this project 4 or 5 years ago, and we couldn't find. We tried to match the studies as best as possible and compare and pool the data to analyze which was better in terms of strictures long term, and neither the short term or long term morbidity was any different in early repair or delayed repair groups. However, delayed repair does tend to cost more, and among the most important factors that really affects the patient's outcome is the expertise of the repairing surgeon. Most of the surgeons that are referred these patients and perform these repairs have performed anywhere from 2 to 5 such repairs. With every case of surgeons' experience that they get, the hazard ratio of death decreases by 11% and the outcomes improve. This is one of the most crucial points in terms of timing of repair. And that was one of the themes that we got from our pool data analysis. In summary,
can I make a comment about something you just said? This is Bill Hawkins.
Yes, sir.
Dr. Hawkins.
Yeah, these are not comparable groups,
Yes.
right? I mean, most of us who do biliary injury select patients for immediate repair and select patients for delayed repair. And so when you look in the literature about immediate repair versus delayed repair, if you are comparing my immediate repairs to my delayed repairs, they're not the same patients. So I think that a comparison like this is just impossible to do. And then to draw conclusions because this comparison has been done is fraught with problems to try to draw a conclusion from such a study.
Bill, I think your point is very well taken. I think what Dr. Jackson is trying to present to basically say that we know that delayed patients cost more, obviously have more procedures, have more comorbidity. So if we can do somebody early, we should. Obviously, we don't want to take early patients that can be done early and put them in a delayed group. But you're absolutely right. There are different groups, and we're not necessarily trying to compare them, but obviously trying to say that if somebody can be done early, they should be done early.
Thank you so much for that comment, sir. In summary, if the patient's clinical status, the hospital facilities and expertise allows us, and early repair is always preferred. In terms of repair techniques, there's multiple right in the literature. There's really no study to prove one is better than the other. The reason why medical is, as everybody mentioned, as the most common prevalent techniques that are used, and the HJ has very good outcomes as well. The most important things when we make these anastomosis is, as Dr. Martini mentioned, the vascularity of the anastomosis and the lack of tension. And the HJ in this regard has great outcomes with 2-year and 5-year stricture-free survival of 95 to 88%. And we often use the Hep-Quinault method to use the lateral component of the transverse component of the left hepatic duct to make it a nice wide anastomosis, especially in those injuries which are approaching the confluence. And they have a leak rate of about 3%. A short-term morbidity is not 15%, but over the long term, the stricture rates are fairly acceptable. And even if they do stricture, 66% of them are amenable to percutaneous measures, and some of them do require revisional surgery with good success as well. We're going to move on to our next patient. This is a 62-year-old male who presented to us with a history of prior pancreatitis for cholecystectomy. Actually presented to an outside hospital for a cholecystectomy. During the procedure, there was concern that an accessory duct was injured and transected, and the patient immediately transferred to our. We performed an MRCP at our institution, and it looked like an E4 injury, but we were unable to discern any bile, any hepatic branches at the posterior sectional, from the posterior sectional part of the liver. We performed a contrastive CT scan to look for any vascular injury. None was found. Then we offered the patient a repair 2 days after the index operation. Open fashion. Upon performing the laparotomy, we didn't find any bilious spillage. Clips were noted at the hilum, and we took that off and performed cholangiograms. We were able to identify medial section, branches.
So, Dr. Jackson, just everyone, just if you're talking, please. Somebody's mic is not muted, and they're talking. Please mute your phone. Thank you.
And we were hoping that intraoperatively, as we performed our, we would be able to find sectional radicals. However, we still had lots of difficulty. We spent approximately 2 hours to dissect the hilum, trying to identify the posterior sectional branches. But at the end, we performed a wide hepatocystectomy, hoping that it would encompass all of our biliary radicals. This is an MRCP that was performed on this patient at 1 month post-op. Again, we could see a lack of opacification of the bile ducts from the right posterior section. This is at 6 months post-op. By this time, the patient had gotten admitted to us several times with recurrent episodes of cholangitis. At this time, we were obviously concerned that we had a stricture at our anastomosis, or we had a disconnected duct which was causing these problems. And these were how he presented in terms of labs at both of these times. Fortunately, we had a very skilled interventional radiologist who performed a percutaneous biliary drainage on this patient. He was able to identify a stricture at the left side of the, and once again, we could not opacify. I'm sorry, he was able to identify the right side of HJ. He could not identify the right posterior sectional branches. He was able to internalize this drain though, and at this time, we offered the patient an operation. But before we proceed to what we did, I would like to bring up some more nuances. What should have been our next best step when we could not identify the right posterior sectional branches on our MRCP? Should we have placed PTBDs right off the bat?
Do you know where it's patient Danita?
And also, what should be our next best course of action now that we've identified a stricture in the left side of the HJ and we can't identify, I'm sorry, the right side of the HJ, and we can't identify the right posterior sectional branches?
So thank you, Dr. Jackson. So a lot of a complex case, a lot of different things to discuss. Let me start with Dr. Rebecca Kim, if I could. So here's a patient that we can even go back, maybe go back, Dr. Jackson, to the first slide of this patient, just to kind of refresh the presentation there. Okay, so here, that's the information of this patient. He comes in with an E4 injury. Well, it's not, you don't really know it's necessarily an E4 because you have an MRCP that's incomplete. The patient seems to be stable. There's no evidence of any vascular injury. And so what do you do? Any further imaging here? Would you do a PTBD beforehand? Because basically you have part or a hole of the right liver that's not mapped. Or do you perceive the operating room as they did? Thoughts or questions on that?
Yes, so this is Rebecca Kim from MCW. So I guess with this imaging, I'm not exactly sure what's going on. There is a CTA, is that correct? That shows vascular injury?
No, the CTA shows no vascular injury.
No vascular injury. Am I able to visualize, like, what does the right side of the liver look like?
Decompressed ducts. You don't see anything on the right side of the liver. They're not dilated, so you don't see the ducts.
So non-dilated ducts on the right. And then if I'm interpreting this MRCP correctly, are those dilated ducts on the left side? Sorry.
Correct. It looks like you can see ducts on the MRCP. You can see the left. It's really hard to know whether those ducts that you see on the middle part of the liver, whether that's a large segment 4 or the right anterior. But what's for sure is the right posterior does not show up.
Right.
And now you're preoperatively, so what do you do?
Sorry. Bile? Is there bile in the drain?
There is.
So then there's presumed leak, but the right posteriors are decompressed and not occluded. But they could also be the ones that are leaking.
It's kind of it's a question really of whether you attempt to map the entire biliary tree pre-op, or whether you feel that whether you will map it intra-op. And there's kind of a pros and cons to both sides. In this case, they went to the operating room with the plan to map it intra-op. What do you think?
My preference would be to try to get as much data beforehand if possible. I guess the question is, as I'm just thinking out loud, so I've got a CTA, I've also got an MRCP, but I still am not sure what's going on that right side. But I know I've got bile in the drain. I don't really know what other images I could.
So the problem with trying to do a PTC preoperatively is that it'd be a non-dilated bile duct. And they can be very difficult to do, very difficult to access. You usually have to do them under general anesthesia. So, but those are really your options.
No, absolutely. You're spot on. That's actually what I was trying to get at. In this case, this is a situation where if you are the type of person that you feel that mapping the liver entirely before going to the operating room is the way to go, to basically being a delayed situation where you would wait a few weeks where the ducts would dilate, then do a retrograde cholangiogram using your drain, and then put a PTC and then go to the OR. It's not what's right or wrong. It's just a different way of thinking. Going to the operating room directly like that was done here is not wrong. It just basically puts you in a situation where you basically have to find all the ducts which are small and non-dilated intraoperatively. So, but let's go on to Dr. Elisa. Thank you, Dr. Kim. Dr. Elisa from Cleveland Clinic. So you're in the operating room. You have this patient, and you can't find the right posterior sectional duct. As you heard, they spend hours. So what do you do now? I'm not sure Dr. Elisa is still with us. So how about we ask that question to Duke, Dr. John Creasy? You there?
Yeah. Huh? I don't want you sitting at the side like that, and then I'm not right here. No.
So I'm in the operating room and I can't find the right posterior duct.
That is correct. Let me repeat the question. You have a 62-year-old that comes in with a CTA negative, so no evidence of vascular injury. You get an MRCP. You have the left. You can see the left liver ducts. You can't see the right. You're in the operating room. You can see your left ducts, but you can't find your right posterior sectional duct. It's a difficult question. You can pick on somebody else if you want.
Well, I would say I think I would make the anastomosis with what I had and then leave wide drains there.
Yeah. So it's not an easy question. We said certainly this is a place where all will ask for a second eye, second pair of eyes is always helpful. Obviously, the challenge is the right posterior sectional ducts are probably the more variable of go to what's called a Charcot's crook around the right anterior. So all of these are challenges, and there's a lot of different things that people can do, including taking down the cystic plate, including calling IR if you can, and try to do a stick and do a retrograde cholangiogram, but that's very challenging, as you heard, because it's decompressed. Any thoughts or questions on how anybody here would approach that situation? It's not an easy situation. Comments, thoughts?
I mean, the challenge here is that, so I like the idea of I'm an early repairer in general, but there are definitely cases that you punt to late, right? So, and that can be infection or that could be uncertain anatomy. Because the just repair what you've got is then where this ended up, which is now the patient probably needs a posterior sectorectomy, but it's a delayed fashion, and you have the possibility of disrupting your prior anastomosis. Whereas to go to the operating room, do an HJ to the left side and right anterior sector, and then hope that the right side's going to dry up, significant hope that you might not get there. And the is actually disrupting whatever you have for early adhesions, is actually reducing the possibility that that right posterior sector is just going to scar in, because sometimes it does. And sometimes you don't have to deal with it, obviously, and somebody divides it and it just retracts in and that liver atrophies. But it's hard to go and to do an HJ to a portion of the liver knowing that you've left a portion of the liver undrained. And if I'm only 2 days in like this one and I have relatively pristine anatomy and I've done an intraoperative cholangiogram and I really am quite certain that I do not know where the right posterior sector ducts are, unless there's something that means that the resection is unsafe or is really going to be extra challenging, I would probably bite the big segment of liver that I've just left out in the breeze, knowing that I'm buying a really bad problem a little ways down the road that I don't have a real way out of.
Well, that's a very, thanks for thinking out loud there, Brandon. That's actually very well said. I mean, honestly, as I said, Dr. J. Raj and his group obviously are bringing cases that make us think, which we certainly all appreciate that. This is one of the situations that even with a no vascular injury, a non-septic patient, I still will delay to late because, as you said, I mean, if I leave this patient 3-4 weeks, I wouldn't wait 6 to 8 weeks, but 3-4 weeks, bringing them back for a retrograde cholangiogram, and then put a PTBD, a PTC, and then take them to the OR. Because my worry is that this patient doesn't only have an E. My worry is that they have an E and a C, so an aberrant right posterior sectional duct and an E injury, which those are very hard to find sometimes, and they're sometimes very hepatic. Anyone else thoughts on this? It's a challenging topic for sure. So any comments or thoughts from anybody?
Oh, this is Mike Jacobs. I mean, if it were me and I couldn't identify the right posterior sectoral duct intraoperatively, for me personally, I would just leave a drain and wait and let it declare itself. In the instant, well, I mean, one of three things is going to happen: either nothing, it'll wall itself off in stricture, for which case you'll get some elevated liver enzymes. You're not probably likely to get cholangitis in the absence of other colonization. At that point, you may have the decision to do one of two things. You can either PTC it and leave a catheter in place, and if you feel it's a large enough section of liver, you can use the PTC as an access site so that when you operate, you can more easily find it. You just thread it, either wire over it or thread it through, or alternatively just do a completion right hepatectomy of whatever segment's necessary. I would wait a little bit.
Well, that's essentially what they did here. So, Dr. Jackson, if you could forward the slides to your questions. And in this case, what happened is that they were able to then do a PTC, and actually the IR team was able to actually internalize that as well. So the aberrant duct, or the right posterior sectional duct, wasn't really far from their anastomosis, but it was able to be internalized. Now, as always in these situations, what happens is that these are probably the highest risk anastomoses, if you will, for stricturing, and that's what happens. So now you have, forget about how we got here, but the next question is, you have a type C injury, in other words, an aberrant right posterior sectional duct that actually you repair, and it's strictures. These things stricture for many reasons. One of the reasons may be that they have aberrant anatomy, arterial anatomy. But the question is, how do you handle a right posterior sectional duct that strictures? And so, Dr. Jackson, do you want to? Well, actually, let's just stop there for a second and ask some more questions. So you have a right posterior sectional duct that strictures. Let's go to Dr. Beckman. Are you there, Michael Beckman?
I'm here.
What's your thoughts on a type C injury, right posterior sectional duct that you repaired and strictures? Whether in this case they did it with a PTC, but whether that or surgical anastomosis, doesn't matter. They're high.
I have a stricture at an HJ in the right posterior duct. We would generally use a percutaneous biliary drain and leave that in place for a long time, maybe 6 months, and see how that allows it to stay open.
I think that sounds like a good option. In fact, actually, Dr. Jackson, if you remind me, you actually did that in this case and it recurred. Is that correct?
Correct. So this gentleman underwent at least 4 PTBD replacements, and every time we would check it, perform a manometry, it would always be a stricture there.
So Dr. Beckman, that's where you are. You've done that. Now the patient continues with a stricture and right posterior sectional duct.
So they continue with the stricture. It seems like we're saying that this stricture is not going to improve, rather than it would be worth looking at a cholangiogram and seeing how long the stricture is. I think if it's a short stricture, it may be able to be revised, or they may need a right posterior sectionectomy.
So that's thanks for bringing those two options. Anyone feel strongly one way or another? I have to say that I have an opinion, but I'll wait to see. Would anyone say? I know that Brendan, you mentioned the resection option. Anyone
I would take it out. Take it out.
Yeah, Jacob's here. Don't bother revising that. If the PTCD doesn't work over multiple times, then just take it out. You're not going to fix that problem at that point. There's no blood supply left.
I think it sounds, you've heard, I concur with that completely. I think it's one thing to have a stricture to the hilum, obviously repair it, revise it. If you have a stricture to the left duct, revise it. But if you have a stricture to an aberrant right posterior sectional duct, I think most of us feel that's a resection candidate. I personally have revised them, but I've regretted revising them, so now I resect them. But go ahead, Dr. Jackson. Would you give us your summary there, and then I think we'll stop and we won't go to the third question. This has been actually, we covered a lot of the third patient's topics here as well. But please proceed.
Perfect. Thank you everybody for your comments. And we truly got lucky in this gentleman. However, he was a morbidly obese gentleman, had a fatty liver, and even though we were prepared to do a hepatectomy, a right posterior sectional hepatectomy in this gentleman, because we got lucky, we took our chance. We did revise this anastomosis, and so far he's done okay. Now, in terms of PTBDs, there's two schools of thought. There were multiple articles from a few centers which would routinely place PTBDs in all of their bile duct injuries, and the thought behind that was to define anatomy most accurately, as this was thought to be the gold standard in defining anatomy. Control sepsis, facilitate reconstruction, and many of these drains were left in place for as long as 14 months to allow for post-operative cholangiography and interventions. Now, there are some reasons not to leave PTBDs also. They do have a real but low 2% risk of major complications. Here are a couple of pictures of a portovenogram and a hepatic arteriogram performed during PTBD placements. And another reason why not to do PTBDs is even though it may not be as good as a percutaneous biliary mapping, modern-day MRIs are quite good, and they are able to give us a good idea about the anatomy. We're going to skip our last case and move on to discussing hepatectomy as an option for treating bile duct injuries. Hepatectomy is usually indicated in patients with E3 or E4 injuries, particularly those who have a concomitant vascular injury. Many of these patients would present with liver atrophy, recurrent abscesses, recurrent cholangitis, or would have had previous repairs which would have strictured, like in our case. Very, very rarely are these indicated in an urgent fashion, and there was very few cases that were published, performed in an urgent fashion, and they had a high mortality. The usual interval between the index operation and hepatectomy is anywhere from 43 to 62 months. And most patients would undergo at least 1 to 2 repairs prior to getting a hepatectomy. In terms of short-term outcomes, hepatectomy does come with a fair share of morbidity, most commonly bile leaks, liver failure, hemorrhage, ascites. But they do present a good long-term outcome with no strictures or reinterventions up to 62 months. And these were multiple other papers, which with low numbers, but with decent outcomes. Finally, liver transplantation is also an option for bile duct injuries, typically indicated in patients who have secondary biliary cirrhosis and liver failure from bile duct injuries. Very, very rarely are these performed in emergent fashion. There's a good study from the Spanish, a good paper from the Spanish liver transplant group, which showed their short-term and long-term outcomes after emergent and elective transplantations for bile duct injuries. And those that were performed over a short term had up to 50% 30-day mortality. But long-term outcomes were reasonable. But we have to remember that this is benign disease, and the patients incur a lot of morbidity to undergo this procedure. So it's definitely not first or second choice. Another caveat to liver transplantation is the time on the waiting list. Typically, time on the waiting list can range anywhere from 2 to 3 years, and the mean time from the index operation to transplant, to resorting to transplant, is up to 60 months. Well, that's about it. Thank you, everybody, for listening. I wanted to introduce everybody to Cooper. This is my child, and he helps me with all of my papers. Thank you, Dr. Al-Saidi. Thank you to all my teachers. Thank you again.
Well done, Dr. Jackson. Thanks, everyone, and we're finished.
Can I just a couple of comments?
Please.
So a couple of things. We wanted to show you cases that did not show that necessarily we'd done a perfect job of things. I think in that second case, if the patient was not obese, we would have ended up doing a resection. He had some underlying liver disease also, which was an issue. In the third case that we were going to show, we did actually a right-sided resection after he was sent to us with multiple issues. The second thing is, fellows, please remember, look at your pattern of LFTs, because if you have a normal bilirubin but an elevated alkaline phosphatase, that tells you that a duct is obstructed somewhere. So the pattern of LFT elevation with an obstructed right posterior duct with a draining anterior sectoral and left duct is going to be a normal bilirubin with an elevated alkaline phosphatase. So really pay attention to that. And then the third point I just wanted to make for everyone is, with that case, we all tried in the operating room. We called a friend. So, my partners came in, and then I actually even called Dr. Al-Saidi for advice regarding what to do in this case. You should never be too proud to call for help, especially in these cases. And last of all, remember, you will be sitting in with a lawyer with pretty much every one of these cases. And I always tell my referring doctors that send me a bile duct case, these are your best referrers in the future if you handle them right. The surgeon, I mean. And second of all, your documentation needs to be pristine, because the clock is ticking with you now. Thank you, Adnan.
Thank you, Ron. Thank you very much. Thanks, everyone, and thanks, Jill. Well done, Dr. Jackson, and thanks for all the fellows who participated. You guys have a good day.
All right, thank you.